This program is brought to you by Emory University.
Welcome to our Monday morning grand rounds. It's a great honor for me and a pleasure to introduce our speaker this morning, Dr. Bill Gray from Columbia. He's kind enough, he's returning from Miami where he was doing a fellows teaching program over there. If I have to summarize Bill, what he has been doing, he's a trailblazer in the field of cardiology and has been developing devices and treating patients and has helped the field of cardiology advance in providing care to our patients with minimally invasive work. He's the Director of Endovascular Services at Columbia, and he's very well known for his battles with carotid stenting. But he is not just limited to that, treats coronary artery disease and all other aspects. Today he's going to talk about a formidable challenge that we all face in our clinics when we see patients with atrial fibrillation and the risk of stroke, So he's going to talk to us about that with some of the newer devices and the medications that are available and how we should approach our patients with that. Bill, greatly appreciate you taking the time out.
Khusro, thanks very much for a kind introduction and for being a great host. We had a great meal last night. So the prelude to this talk is really one where we have a new device approved. The Watchman device was just approved about 2 months ago by the FDA for the treatment of patients with atrial fibrillation to prevent stroke should they decide to come off warfarin therapies. And I think it's a unique opportunity because in intervention, we typically replace a surgical approach with an interventional approach. And in this case, we're replacing a medical approach with an interventional approach, which is unique in our experience. I think the only other thing I can think of in a major way would be renal denervation, and we all know how that went or is going. So in a sense, this is a path that we haven't gone down very often. And the metrics for measuring the differences between what goes on in medicine and the complications that occur with a medical approach versus the complications and the benefits from a interventional approach are different. In some ways, I call them orthogonal to each other. They're not talking the same language because you're talking about bleeding risk on one hand and procedural risk on another hand. And so there gets to be a whole difficult analysis. What I hope to do today is to kind of break that down for us and at least provide some justification for a device approach to left atrial appendage occlusion for atrial fibrillation. Not that I think that I know the answer in the individual patient, but at least that there's some grounding in fact and data that we could use to inform us. So here are my disclosures. I work with Coherix Medical very early in device development and preclinical testing. Boston Scientific has supported us in institutional research. And Central Heart, I'm actually consulting now, and if they ever get a trial to the FDA, I'll be one of the co-principal investigators. So here are my disclosures. I've already said this. The role of atrial appendage is not well defined yet, occlusion. All implantable devices, except now, this is actually an old one, remain investigational except for the Watchman device, and I am not an electrophysiologist. So what does a patient with atrial fibrillation really want? Well, if you break it down, they'd like to be in a regular rhythm, not have to take medication. What we can offer in that regard is medication, which, as most people know, has modest to moderate effectiveness, depending on the patient, their time in atrial fibrillation. But in general, there's less effectiveness over time. And amiodarone, although is the most effective, may have irreversible side effects. We can offer ablation as a potential solution. But if I talk to my electrophysiologist about ablation, and in fact, it takes multiple goes at ablation usually to get successful outcome. And in fact, most patients who get ablated don't come off warfarin therapy. And if you look at the complication rates, they're not insignificant. And we've already talked about the need for multiple redos. So, in the recommendations for AFib ablation, there is actually a caveat that says that patients really should still consider long-term anticoagulation. Surgical maze is effective but invasive. So if you can't be in sinus rhythm, what's the next best thing? Well, the next best thing is to avoid stroke. And we talk about CHAD scoring, and this is going to be one of the bases of our conversation today. And I want to set this up so we can really understand it. First of all, the CHAD score came from some older data from atrial fibrillation trials, and you can see the patients that actually was used to populate the risks for the CHAD scoring. And it's based, as we all know, on hypertension, heart failure, age, diabetes, and stroke. Stroke gets 2 points. And as you add the points up, the stroke risk increases significantly. By the time you get to 3 and 4, the per annum risk of stroke is somewhere between 6 to 9, 10% per year. So it's not insignificant. And in patients, as you imagine trials, you're going to imagine that you want to test the most risky things in the most at-risk patients. There are some issues with the CHAD score. The low end of the score is not that sensitive. For instance, a man less than 50 with lone AF equals a man over 74 with prior carotid disease and MI. So there's some issue around how the scoring system is set up. And there are other factors not included in the CHAD score, which we know predict stroke, including female age, female sex, age over 65, not just 75, renal hepatic disease, prior cardiovascular, cerebral vascular disease, and so on. So that led to the development of the CHADS2 VASC score, and I put it in here. Again, from a base of patients and their outcomes, and you can see the scoring here. Now, I'm not going to go into some of this in too much depth because I'm not going to use this as our scoring system. This system wasn't used in most of the trials I'm going to go through, but you can look for it in a trial coming to you soon. Now, there are other risk factors which have been defined by transesophageal echocardiography. And for those of you who do this, you understand that the degree of spontaneous echo contrast, left atrial volume, low left atrial velocities, aortic plaque, which is an independent risk factor, obviously, and the morphology of the left atrial appendage may, in fact, predict risk of stroke as well. And we have a buffet, a vegetable buffet of different types of echocardiographic appearances: chicken wings, cauliflowers, broccolis, and so on. And in fact, there are some small studies that suggest that the morphology of the left atrial appendage may, in fact, have some predictive quality, but we don't use that routinely in practice. But as you can see, and I'll bring this back home later on, that the left atrial appendage is like a snowflake. There isn't one that's just like another. And each one of them has a quality of depth and orientation and orifice size and lack of concentric circular quality that actually make it difficult to manipulate from a procedural standpoint. What we don't have, and I'll just stop for a second, what we don't have is a mix of the CHADS2 or CHADS2 VASC score and the echocardiographic scoring system, right? And I've challenged my echocardiographers to try to come up with something that would score patients who have echo scoring and CHAD scoring and figure out how the two overlap. What I'm saying to you is, let's say you had a CHAD score of 1, but a very low left atrial velocity and heavy trabeculated left atrium and a cauliflower type thing. Well, is the patient more at risk than a usual CHADS1 or less at risk? And so I think that's a very interesting intersection which we haven't fully explored yet. We do know that stroke reduction with warfarin works. It's been the cornerstone for the last 25 years. And for anybody with a CHADS2 over 1, we typically would offer them or at least consider Coumadin therapy. It does provide a 60 to 70% risk reduction versus no treatment, and it provides a 30 to 40% risk reduction versus aspirin. And that's an important fact that I'm going to show you later on, some calculations I did versus aspirin on some of these outcomes. As we all know, there are challenges with warfarin therapy. The therapeutic window is relatively narrow. It's underutilized, and I don't think I have the slide. Let me see if I did that. Yeah, I don't have it. But there's multiple surveys that show that if you look at patients who should be on warfarin, who are actually getting warfarin, it's probably less than 30. It's probably less than 60% of the patients who should be are actually getting it. And the reasons they don't get it has to do with dietary restrictions, frequent blood testing, non-compliance. And in fact, if you look at the studies that have examined patients' time in therapeutic window for warfarin, it's actually not great. In the best studies, which I'll show you some here in a minute, for the best studies, patients, if you get a patient in a therapeutic window more than 60% of the time, you're doing really, really well. And that means they're either too high or too low. And the too high is the one that probably is putting them most at risk, which I'll show you in a minute here. So enter the novel oral anticoagulants, the NOACs. And the NOACs have been developed to do a couple of different things, but the most important thing is they provide a level of compliance and lack of testing which is unique and compared to warfarin. So the novel oral anticoagulations don't require frequent testing, and if you just take them, they work. Dabigatran here was the first to be tested. It's a direct thrombin inhibitor. The others are anti-10A inhibitors, and so they work different mechanistically, but they have very similar effects. So what I'm going to go through now is a series of slides that are going to break down the data that are available for the NOACs. And these are data that many of us, have not carefully examined. And I was talking to Khusro last night. And when you actually examine them, there's some very interesting facts about them. So the first is the RELY trial. And this looked at dabigatran. First thing to notice is that it's 18,000 patients, and I think some of the more senior folks in the room can say that if you have a trial of 18,000 patients, it means one of a couple of things. Either the event rates are not very high, and or the differential effect of whatever you're testing is relatively low in relationship to that event rate. And in the case of atrial fibrillation and anticoagulation, both are true. So you have relatively low event rates, and you have the nominal difference between the treated arm and the control arm is relatively small, and I'll show you that in a minute. So it takes 18,000 patients to show that. In this case, the age was about 72, and the CHAD score is about 2.1. And the reason I highlight those is because I want to show future trials or other trials, and the only way to really contextualize these trials, you can't compare them directly, but you can contextualize them, is to line up some of these features which help you understand the population that was being tested. So if we look at the population being tested here, and major bleeding, and I'm going to highlight the bleeding outcomes here in a moment. Major bleeding for the lower dose of the active treatment group was about 2.5%, about 3% for the higher dose, and warfarin was about 3.5%. Okay, so if we look at all bleeding, it was 15%, 16%, and 18%. So those are big numbers, okay? This is on a per annum basis. So the ROCKET trial looked at rivaroxaban, an anti-10A agent. This trial had 14,000 patients, so again in the same spectrum or size trial, age 73, so similar. The CHAD score was 3, not 2. So the population was, generally speaking, a little more at risk for stroke, and you're going to see differences in outcomes in a minute about that. The major or non-major clinically relevant bleeding was in the 20% range in both warfarin and the rivaroxaban arms, so not materially different. Actually, sorry, it's 15%. This is event rates per 100 patient years, which is roughly equivalent to a percentage. If you look at any major bleeding, it was 3.5% in both arms. So we had about 2.5% in the other arms. We have 3.5% in this arm. Interestingly, warfarin was about 3.5% in the other arm as well. So we have some consistency across arms. Now we're going to look at Aristotle, which looked at apixaban. And in this trial, another 18,000 patient trial, our age was a little younger, and the CHAD score was much more like the RELY trial. And we can see that the major bleeding was 2% in the apixaban group and 3% in the warfarin group, again, more or less coming in line with the prior trials. And if we look at the any bleeding rates, we're in the 18 and 25% range. So these are not insignificant numbers. Is anybody shocked by these numbers? Nobody's shocked by these numbers. Everybody takes care of patients with atrial fibrillation. Okay, good. So now let's look at the benefit that what we're buying for that risk, because that's really what we're doing here. So for RELY, well, we'll put them all up there. So for RELY, in the higher dose, we had a 1.5% risk of stroke per year. This is in a CHAD score of about 2. In the lower dose, about 1.5, and in the warfarin group, about 1, a little bit more than 1.5. So the higher group seemed to have the biggest effect. In the ROCKET trial, it was about a 0.5% difference, and the Aristotle trial, remember this was a group that was a little bit higher in CHAD scoring. In the Aristotle trial, it was about 0.4% difference. So if you look at the stroke rates on warfarin, they're about 1.5 to 1.7. Again, the CHAD score factors into that. On the NOACs, it's about 1.3. So does anybody know what effect NOACs have to reduce the stroke risk? Are they better oral anticoagulants? That is, do they reduce thromboembolic stroke? Better? This data would suggest they do, right? Okay. So we have a consistent advantage. Very small, that's why it takes 18 to 20,000 patients to see it, but materially important probably for most patients of stroke reduction. So we have the major bleeding benefit of about 0.5% per year over warfarin, and we have the stroke benefit of about 0.4% a year over warfarin. So on balance, and just as a back of the napkin thing I drew out, we have a study drug looking at stroke and warfarin here. So it's different, but not big. Okay, so the stroke differential is not what you're really buying here. What you're buying is convenience. What you're paying for is this bleeding rate. And I only graphed out bleeding in 2 years, but this is all bleeding rates. If I did just major bleeding, it would be in the 12 range. So here actually is the kicker, and this is the thing that if you don't really dive into the data, you don't see it. It's the bleeding stupid, right? So the primary outcome of stroke or some systemic embolism is better in the apixaban group, in this particular case for Aristotle. But if you look at thromboembolic stroke, it's not different. Where you buy your benefit is in the prevention of hemorrhagic stroke. So it's about the bleeding in all cases. It's reduction in bleeding, systemic bleeding, and major bleeding, but it's also the stroke benefit comes from reduction in intracranial bleeding. The same thing is true about RELY. If you look at the ischemic stroke, there's no difference in ischemic stroke. It's not a more effective anticoagulant. It just tends to be a safer one in terms of reducing intracranial bleeding. So is that a shock to anybody? You thought they were better anticoagulants, didn't you? I did until I read this data. So we have a marked stroke reduction but continuous hazard of bleeding. And this is true for all medical therapy for pretty much everything we do. Whatever hazard we do, whatever benefit we get, we buy at a continuous hazard of whatever that drug has. In this case, the major hazard is bleeding. So I've drawn this as a positive and negative thing. This is a reduction in stroke. This is an increase in bleeding. And this is major bleeding. This is not insignificant bleeding. Okay. So the other thing about this, and again, if you don't dive into these data, you don't find this, but we know that patients discontinue oral anticoagulants, especially warfarin, because of testing and noncompliance and so on. But in fact, these trials all had a fairly significant rate of discontinuation. And in some of the trials, they analyzed what happened to the patients when they were discontinued. And in fact, those patients went right back to the risks that they would have otherwise had without oral anticoagulation. And you can see here that the rate of discontinuation is at least as high as it was in warfarin. So this is not insignificant. If 1 in 5 or 1 in 4 patients is discontinuing oral anticoagulants for whatever side effect reason, that puts them back at risk. And they may have to go back to warfarin, which puts them at risk for the other things that they were supposedly getting a benefit from on these NOACs. So enter the left atrial appendage occlusion. So first let me pause there and ask if there's any questions. Okay, so left atrial appendage occlusion. Who thought of this? Actually, a guy named Mike Lesh in the Bay Area, who's an electrophysiologist, understood that in most cases, patients who had stroke and atrial fibrillation, the origin of the thromboembolism was the left atrial appendage. And why is that? Because the left atrial appendage is actually a very complex trabeculated, it's the only trabeculated part of the left atrium. And actually, the velocities in here are very slow. It satisfies all of Verko's triad except for the inflammation part. So in fact, it's a setup for thrombus formation. We've already talked about the risk factors, and here's a thrombus in the left atrium, just as one of our patients. And not infrequently, we see patients for procedures for which they've already had TEEs. They're Coumadin intolerant, and I'll go into that patient population in a minute. We've set them up to come back for a atrial appendage occlusion, and 3, 4, 5 weeks later, this is what their echocardiogram looks like, where it was clean the month before. It's scary how quickly and how many times you find asymptomatic but real left atrial appendage thrombus. So it's a dynamic process which is ongoing for most patients. So Mike asked the question, why not just exclude left atrial appendage from the cardiac circulation? The surgeons have been trying to do this for a while, and in fact there are some surgical techniques, which I'll show you in a minute, which have shown more effectiveness. But the open operation to stitch left atrial appendage shut actually hasn't worked that well first of all, there's not a lot of data. There's no stroke-related data on it. But secondarily, if you look at the closure rates, they haven't been that great. And probably the reason has to do with the fact that the heart is deflated. It's not full of blood at the time, and so you don't really get a chance to check the work as you're doing it. There's something called the AtriCure clip, which can go on and actually has pretty good surgical rates of closure, but there are unfortunately no data on stroke reduction. So if you're having an operation and the clip is available, it's reasonable, but it's not going to necessarily prevent stroke because we don't know whether or not it does. Now, I'm a believer that if you close atrial appendage, by whatever means, I suspect it's going to reduce stroke, but we have not proven that in many cases in some of these devices. So I mentioned at the prelude of this talk that one of the issues with replacing a medical therapy with an interventional or surgical therapy is that you have this crosstalk between what the complication rates from medicine and surgery or intervention. So here's a primary example. Primary efficacy endpoints for a medical device or medical treatment would be stroke, systemic embolization, and unexplained death. And safety events for a device would be embolization, bleeding, and pericardial effusions at the time of implantation. And there's an overlap for both safety and efficacy that has to do with hemorrhagic and procedure-related stroke. So you can see that this is not intuitive, and you have to kind of be careful about how you speak about it, but I think we've got a pretty good way of managing the conversation. Okay, so this was Mike's original device. It's kind of the father of the Atritech device. As you can see, very similar in its construction. It looks a little bit more Jurassic Park, but the bottom line is actually it worked pretty well, and I'll show you the data. There were 6 sites in the U.S. that implanted this, U.S. and Europe that implanted this device, and the trial actually was done in patients who had non-valvular AF, 1 additional stroke, so the mean stroke risk, so the mean CHAD score was about 2.5, which is probably appropriate, and had a clinical contraindication to warfarin. So these were patients at risk without lots of options. 38% had prior stroke, so this for them was a secondary prevention strategy. And the primary endpoint was composite of stroke, cardiac or neurologic death, MI, CT surgery within 30 days. So we're looking at the implantation rate complication. So this is I think looking back, this is a fairly bold exploration because we'd never been in the left atrial appendage before for any meaningful reason. We were in this trial, I was in Seattle at the time, and we were in this trial, and it was a little scary, I'll be honest. You know, the device, you had to recapture the device if it wasn't placed correctly. It was a little clunky. You had to take the whole device out of the body. It was tough. But in any event, remarkably, people did quite well. The success rate was quite high. The complication rates were remarkably low, especially as I'll show you in the Watchman trial, where we had even more experience and more complications. And the majority of patients received antiplatelet but not anticoagulation afterwards. Of the patients who were enrolled, there was 1 stroke at 173 days and 1 at 215 days. I was actually the chair of the CEC for this trial, and I will tell you that these strokes were kind of all over the place as an at-risk population. The background risk of stroke for this population is probably 1% to 2% per year without atrial fibrillation. No, I'm not being an apologist for it. I just want to tell you this in the context of the trial, it was interesting. And here's basically, this is the accounting of what happened to patients. The annual stroke rate for this population was 2.2%. For the similar CHADS-2 scoring, it would have been 6.3%. So this is the first inkling that we may actually have a device that, as compared to historical controls, looked like, absent warfarin, was protecting patients from stroke. So that led to this device, actually the son of Plato, called the Watchman device. And this device has undergone several iterations and will undergo several further iterations, because one of the issues around implantation is the fact that these prongs are actually, I'm supposed to stay in front of the camera, sorry. Hi. These prongs can be detrimental on exit. And I'll show you how the device is implanted in a minute, but you'll see that the left atrial appendage is at risk as they come out. So what's going to happen is these prongs will be turned under, and actually it's going to become a continuous loop, so that they're not going to have that same kind of sharp-edged deployment. It's covered with a porous cover, and this is set up for endothelialization. So you're probably all familiar with this. I just don't want to. I want to go through it because, as I've done with the NOACs, I think it's important to kind of tease out the data set. It was a prospective multicenter trial comparing left atrial appendage to warfarin. non-inferiority design. The inclusion criterion, you had to have a CHAS score of more than 1, and the typical exclusion criterion, you couldn't have a lot of heart failure or LVEF less than 30%. The reason had to do with the fact we weren't sure whether that was an independent risk factor for stroke, obviously. So patients were randomized in 2-to-1, therapeutic to control. Follow-up, interestingly, everybody had a TE at 45 days, 6 months, and 1 year, and then biannually every 5 years, up to 5 years. And warfarin was discontinued if there was left atrial appendage closure at 45 days. And closure was defined as having a leak of less than 5 millimeters in diameter. So you could still have a leak. The warfarin group had INRs monitored every 2 weeks. I'm going to show you how well this monitoring led to therapeutic warfarin levels. And then for 6 months, and then monthly after that. So the efficacy endpoints were stroke, systemic embolization, and cardiovascular deaths. And then for the safety endpoints, it was all device-related complications, so I won't read here. And then intracranial and GI bleeds, and any bleed requiring more than 2 units of blood. So this is the way the procedure is done. I'm going to stop it there. So you do a transseptal puncture. It actually turns out that where you put the transseptal location is actually really important. And what we're doing now with CT scanning, we're actually trying to figure out, if you imagine the left atrial appendage here and the septum here, they're on planes which are not necessarily lined up with each other. And what we're trying to do is be as coaxial as we can with this plane, coming from a non-coaxial plane here. So we're trying to figure out how, if we can predict or have some ability to look at where we enter the septum and what shape of catheter might be required to actually achieve a coaxial deployment here. Because if you don't get a coaxial deployment, the plug is off-center and you can promote leaks. So we're actually trying to analyze some of this three-dimensional Cartesian planar imaging to figure out whether or not we can improve overall outcomes. But the bottom line is you do a transseptal puncture. We deeply intubate the left atrial appendage. Now the left atrial appendage, if you stretch it, you can read a newspaper through it. It's very thin and it's very fragile. So it's a good source of bleeding if you're too aggressive. A left atrial appendageogram is performed. That's something I did not learn in my fellowship. I don't know if you teach that here. But now we're learning how to do that. That helps in measuring and orienting the device approach. Obviously, this is all echo-driven. The device is then implanted. And then once we confirm implantation location and we're satisfied with it with a seal, it's unscrewed. Now, this one lines up very nicely. They don't always line up like this, but this is the thing you're looking to achieve. The other thing I want to point about this schematic is that the device is as wide as it is deep. So you actually have to have a appropriately sized and dimensioned left atrial appendage. It has to be deep enough before it bifurcates or turns or becomes a chicken wing to match its orifice. And that doesn't always happen. So not everybody who has left atrial appendage will actually qualify for the procedure because the device won't fit in there. And if you get it too shallow an appendage, you can see that you're going to have problems with these prongs. And then the device is unscrewed and released. And then over the next few weeks, the device endothelializes and it should seal. So this is actually a procedure that we're going to just walk through, having seen that schematic. Hopefully it'll play. It played before. Is that a fire? Saved by the Bell? So do we, oh, my guy's not here. I'm sorry, it's not playing. It did play. That's too bad. Okay, so in any event, you get the idea.
You want to try to exit
The thing, yeah, it seemed to work before. Let's try it.
media not found.
Yeah, but we imported the media and it was found. So anyway, we'll skip that. It's not, you get the idea. Sorry about that. We made every effort to make that work. But I did want to show this one. It's a shame. The echocardiographic imaging is actually quite interesting. So what you see is the device deploy under echocardiographic guidance, and it's a very satisfying thing. So that's too bad. Kuzro, you saw them play, right?
Yeah.
Anyway, I'll get done. I'll finish here. So let's talk about the trial. This is what it looks like in a canine model. Endothelialization is pretty complete and actually provides a continuous surface of the left atrial appendage. In fact, if you're not careful and you put it too deeply, you can make a kind of pseudo-appendage, and there are trabeculations that occur all the way out to the origin of that left atrial appendage. So you really have to be right at the ostium in order to get this done right. So let's talk about the trial. 800 patients in 59 centers. That's a lot of operators. I'll show you what effect that had in a minute. 700 patients randomized 2 to 1. Mean age was 72, so that's not unlike the trials we looked at in the NOACs. That's about right, 72. About two-thirds were men, and the average CHAD score was 2.2. And remember, the NOACs was 2.1, 2.2, except in the Aristotle trial it was 3. So we're actually tracking pretty well with the NOAC trials. And just to walk through what happened to these patients, randomized patients, the Watchman group, there were 14 patients where an implant was not attempted for a variety of reasons. Implant was attempted in 450 patients. In about 10% of those patients, they weren't able to get the device for a variety of reasons. There was a procedural event, or they didn't get the criterion met. There's a series of check boxes you have to make before you can release the device. The device was implanted in about 90% of the patients, and in the vast majority of those patients, about 85% of them, had warfarin discontinued in 45 days at the time of their TE, which demonstrated sealing. In the warfarin group, the vast majority of them did get warfarin. So that's the lineup of the patients and how they played out. So as I said before, 86% of implanted patients discontinued warfarin at 45 days. That was the goal. And at 6 months, 93% of them were off warfarin. So the vast majority of patients in the implanted group and intention to treat were off warfarin. The event rates are here. I'm going to talk about those in a more longitudinal way. So here are the efficacy results in preventing stroke, thromboembolism, and so on. And you can see here that this is the control, this is warfarin, and this is the intervention, this is the device. And you can see that they cross here, and they probably become statistically significant as a differential out to about 3 or 4 years. Remember, it was a non-inferiority trial, not looking for superiority. So at a minimum, we can say that stroke and thromboembolism was reduced by the device as compared to warfarin, or in a similar way as compared to warfarin. And if you look at all stroke, you can say that again they match up well. That it was as effective as warfarin in reducing stroke. But there are these two issues, or these issues at the early onset. There was a fair number of complications on implantation, and if we look at those, we see that they're actually largely occurring in the first 7 days, mostly actually on day 0. And if we play them out, it actually turns out to be related to probably pericardial effusion from either transeptal or most likely from the implantation and a small perforation of the left atrial appendage. There were some ischemic strokes. These are large catheters, 14 French, device embolization once. There was some major bleeding. So there was a host of problems with the early experience here. And if you look at the overall complication rate, primary procedure on the day of procedure, it was 9%. Now, over time, and this is in tertiles in the pivotal trial, so in the first tertile it was 9%, second 4%, third it was 4%, and if you look at the continued access protocol, it was only 2%. So axiomatic in medicine, the more you do, the better you get. The more you understand, the better it is for the patient. So that has basically been recapitulated in all the ways you want to measure this, whether it's implant success or effusion. Those videos ended up not playing. Yeah, it's weird. It's okay. But I would like to see if we can play the next ones because it'll be interesting. So if we line up, remember I put this similar formatting so we could look at it again. Age, about the same as those NOAC trials. CHAD scores, about the same as NOAC trials. Major bleeding was here, 3.5% one-time risk versus continuous risk in the control. Hemorrhagic stroke, again, fairly high in the stroke. This is per patient, 100 years. And now I've drawn this back of the napkin thing again, where we have a one-time risk of implantation and major bleeding over aspirin. I've compared these to aspirin versus the stroke reduction and left atrial appendage, which again accrues to the positive for the patient. And if we put the NOACs and the left atrial appendages occlusions on the same one, again, this is really back of the napkin stuff, but I'm just trying to give you a scale of kind of how these things line up. We see that the stroke reduction is a little bit better for the NOACs, although I think, again, not comparative across trials. The trends are very similar. The difference, I think, has to do with this major bleeding rate, which in the left atrial appendage group is really not seen after the initial implant. So that continuous hazard is ongoing for the NOAC, but not so with the left atrial appendage group. So somebody's actually looked at this in an algebraic way and come up with a way of looking at the net cost benefit of the device as compared to warfarin therapy. And this is interesting. Depending on how you value a quality life year, okay? So 10,000, 25,000, 50,000, 76, and 200,000. I think it used to be that we said it was 50,000, but I think it's over 100,000 now. It's changed. Life has become more valuable, I guess, or something more expensive to maintain. But depending on how you do that, the cost of the device versus warfarin actually starts to become positive after 5 years in anything over a quality value of 10,000. So now we're getting into a place where it makes economic sense for patients and payers to at least think about an alternative to warfarin. And this is not surprising, as you look at the costs, they become amortized over time, and the benefits are obviously increasing over time as it relates to the cost. So it's again, I think this point's been made. It's a cost-effective therapeutic. The quality of life, it turns out, in the PROTECT trial was improved, and it didn't matter which metric you looked at, other than general health, which is interesting. I'm not sure why that was, but overall, everybody did better. Everybody did better with the Watchman device because they didn't have to take warfarin. And here's the kicker, which is interesting. I don't think it was anticipated, but there was actually a material difference, a significant difference in mortality at 4 years. Now, there aren't many things we do as interventionalists that change mortality short of TAVR. And in fact, there was a mortality benefit at 4 years. Now, this was not the primary intent of the trial. It was all-cause mortality, and most people think this is related to the fact that the hemorrhagic bleeding rate, the intracranial bleeds, were reduced in the Watchman arm, and this probably leads to a benefit overall. But as we know, bleeding is not good for most patients, and that's probably the reason. If there's any benefit at all, it's probably related to that. So the FDA looked at these data and said, that's great. The panel actually voted in 2009 to approve, or voted for approval, but FDA thought they wanted more data on that safety signal on the implantation, so they asked for another trial called the PREVAIL trial. I'm not going to bore you with that. I will bore you with the panel votes. 7-5 approval in 2009. Again, once the PREVAIL trial was done and evaluated, a 13-1 approval in 2013, and then another panel in 2014 voted to approve again. And the reason they had an unprecedented third panel was because there was some glitchy stuff going on with warfarin, where the bleeding rates were very low. In spite of those 60,000 patients I showed you in the NOAC trials with warfarin data, the warfarin data was less than 1% on bleeding per year, and the FDA wanted to get some cover on that, so they had a third panel. The device was approved. There are other devices that have been developed, and the development of these devices is largely centered around the idea that you can delink the implantation security from the capping, okay? And in that way, change and make less prominent the need to orient appropriately. So this is the Amplatzer St. Jude device. This device is not in trial yet in the United States. It has been implanted in humans in Europe. I think it's actually approved in Europe. And the bottom line is that it has these barbs that allow implantation into the appendage. It's a fairly shallow device, so it doesn't require that deep appendage like the Watchman device does. And it has this cap, like a sewer grating, that allows you to cover the appendage independent of the attachment. And here are the various iterations. This is the Coherix Wave Crest. This should be in trials sometime later this year or early next year. This one has little tractor arms. So what you do is actually this Gore-Tex covered device is placed in, this is one from our animal lab. We did a lot of preclinical testing on this. This is placed in the left atrial appendage. The tractor arms are then rolled out and the device is attached after you are comfortable with the orientation. So this is another attempt to delink orientation. So there are lots of different ways to close the left atrial appendage. We have the intracardiac and the extracardiac, and I'm going to talk to you about one more closure technique which has no data. We call the central heart lariat technique, or the hybrid approach. So why would somebody volunteer to get their left atrial appendage closed if there's no stroke-related data? Okay, and the answer is because there's no alternative. Watchman requires warfarin for at least 45 days. There is a small trial called the ASAP trial that looked at aspirin and Plavix as an alternative to warfarin, but it's a 70-patient trial in Europe. It wasn't well controlled. There will be larger registries in the United States that will hopefully remove the requirement for warfarin for Watchman. We don't have that yet. So strictly speaking, on IFU, you're required to have it, and there have been thrombus reported on these devices. You can imagine it's a setup for that because low flows, atrial fibrillation, and so on, large atria. So the bottom line is that we have patients who are sent to us largely from stroke neurology who have had intracranial bleeds or thromboembolic strokes, but who cannot take warfarin. So there's actually a fairly sizable population of patients who can't, or who are, honest to God, can't take warfarin patients. And in fact, I'm meeting weekly with the Central Heart group, and we're working with a analysis from two different databases, VA and Truven, looking at trying to figure out exactly how to characterize that population and how big the population actually is. And it turns out to be fairly significant. So we're doing that to try to get ready to submit to the FDA and get those data together. Now, this is where I'd really love these things to play. Is there any way to?
Let's just plug your hard drive.
You want to just do that?
Yeah, because I think that's where they were coming from.
Yeah, so one of the things that happens here is that we have to get anybody here an electrophysiologist? Yeah, so you are, okay. So do you do dry taps of the pericardium?
I'm not.
Paul does, okay, so yeah. Mike, sorry. So the bottom line is that as interventionalists, we're not comfortable with that. We never, and I thought this was going to be the biggest deal of the whole thing, which was that we had to get a pericardial access. It turns out that the pericardial access was a lot less problematic than I thought it was going to be, and it was a lot less scary. I want to show you that technique because it was, there it is, okay. So it turns out it didn't transfer, I guess.
We didn't, we're like, it's okay.
Okay, so good, so we're back in business here. So the way this is done, this is the patient's we put the II in the lateral position. We go subxiphoid like you would for a typical pericardial approach. A little contrast, a half strength contrast in the syringe. We use a Padjunk needle which has a little curved tip that actually points everything up, covers the tip but still penetrating. And as you can see here, we've put into place some contrast in the pericardium, and that allows us to see kind of a tenting of the pericardium. Once that tent gives way, it kind of pops. You're probably already in the pericardium, and you can see here that now we're injecting contrast, and we can see the flow of contrast in the pericardium. Space is not very big, but actually is reasonably reliably obtained and reasonably safely. So the next thing that happens, and I was telling Kuzra, I showed him this already, this is the best part of the day when you're doing these procedures. We do a transeptal puncture, we take a magnet-tipped wire, and we put that in left atrial appendage tip. And that's located specifically by echo into the appropriate appendage branch or lobe. And then we take another magnet-tipped wire, and we put that through the pericardial sheath that we've placed after we've gotten access to the pericardium, and then we take the two magnets and we pair them up. Bingo. So once they've been paired up, now you have a rail, intracardiac to extracardiac, that you can move your lasso over to snare the left atrial appendage. So before I go into that whole procedure, it's probably important to acknowledge that there's a lot of preparatory work goes into this. These patients all have CT angiograms, and we characterize the left atrial appendages. They have echocardiograms that characterize the left atrial appendages, both by size and shape. If a patient has a chicken wing tucked up behind the pulmonary artery, we can't do this procedure. If it's too wide, in most cases, we won't be able to do the procedure, although we figured out a way to do that. Many times the atrial appendage is like an anchor, and you can actually slip the device over like this and get into the atrial appendage neck, which may not be that wide. So there's lots of ways to do it, but it is an imaging intense procedure. And I would say that about 25 to 30% of patients won't qualify for the procedure anatomically. And another bunch of patients won't qualify because they've already had a sternotomy. And if you've interrupted the pericardium, you can't do this procedure. So this procedure has limitations in a significant way. The next thing we do is we slide a lasso over this magnet arrangement, and we put a balloon inside the left atrial appendage. So this is outside the heart, this is inside the heart. I'm going to show you that in a moment. So this is the balloon inside the left atrial appendage, and we kind of co-locate the edge of this balloon with where we want to actually close the appendage. So the appendage that balloon will serve as a marker for the closure of the appendage. So now we're going to actually take this. Now remember, the snare is nitinol, and within that nitinol there's a suture. So the suture will be pulled out through a skive in the nitinol once the nitinol has been tamped down, and we like our position. But that won't happen. That won't happen. We can release the nitinol closure as many times as we want, as long as we haven't deployed the suture. So let's try to watch this. So you're going to see us. It's just a drawback on a thumb control, and we're now cinching the left atrial appendage. Magnets come apart, but they're no longer necessary, and that's what it looks like when you're done. So here's what it looks like on echocardiography. We've taken the balloon down in this particular case. You're going to see that this is left atrial appendage here. You're going to see it close up. See it closing? Now it's gone. And this is what it looks like after suture tightening and color flow. You can see it here. It used to be here. It's gone now. And there's no flow into it. So let me just tell you about our experience with this. Our own experience, we've done about 40, 45 cases. We've had one major complication. We required a sternotomy for a perforation of the RV where we actually put the small sheath in there. A patient had renal failure, and she had pericardial effusion and adhesions. We didn't acknowledge that or know that beforehand. And actually, when we went back in, we actually finished the procedure, but in order to get access to her pericardium, we had to march all the way out inframammary to get in there because she had adhesions all the way out. So that was a learning experience for us. There have been two other patients that had prolonged pericardial drainage, probably from a avulsion or potentially from the transeptal puncture. There's a host of patients who have some pericarditis afterwards because it's not insignificant what you're doing to their pericardium. We try to get these sheaths out quickly. So if the patient has no blood and no drainage after a couple of hours, we pull the sheaths. And that actually reduces the pericardial inflammation a lot. And we actually only offer this, we triage all patients to Watchman first because we believe there's no ethical basis to do this unless there's no other alternative for the patient because we don't have any stroke-related data here. To my knowledge, nobody's had a stroke. We're in the process of getting those data in those 40 patients, but we'll see. And we're currently in the process, as I mentioned before, of trying to get a submission to the FDA for the oral anticoagulation patients. So in conclusion, warfarin risks are well established. The benefits are well established as well. The Watchman closure concept has actually demonstrated that promise and I think effectiveness and cost effectiveness versus warfarin. And and I wrote here approval imminent. That's how new the approval is. It's the first randomized trial data that we have. I think that this is the question of the day. NOAC and left atrial appendage probably provide roughly even stroke benefit reduction versus warfarin. The stroke reduction in NOAC is due to fewer hemorrhagic strokes, and we believe that's probably the case for Watchman 2. NOACs have slightly less bleeding risk than warfarin, but remains a continuous hazard through treatment. There is a hazard with left atrial appendage, but it's one time and upfront. So long as a patient has a reasonable lifespan, it seems like a reasonable alternative for them. And as we continue to reduce procedural risk, I think those benefits accrue to the patient. Like all therapies, the patient selection is critical. High CHAD score patients are probably the ones who can't take oral anticoagulants, will be the ones who we offer valeriate. Current oral anticoagulant patients who prefer not to take them or young active survivors who don't want to take them will also be offered Watchman. And the novel devices and drugs may tip the scale. And as we start to look at NOACs versus devices in the future, and I suspect that's what will happen, new data will be developed and we'll be able to answer some of the questions that currently are kind of still outstanding. So with that, I'll end up on this side of the equation. Khusro asked me to give one slide on carotid stenting, which is totally unrelated. but I thought I'd stop here first and ask about if there are any questions on NOACs and left atrial appendage occlusion.
I guess just to ask your comments on the recent surgical literature talks about that anytime you mess with the atrial appendage, you have an increased incidence of atrial fibrillation, went up by 40%, the particular study. Have you seen that, and what's your response? My look at that is it's very sophisticated. I couldn't see that that will ever apply generally. I mean, I just, to try to get people to do that on a big time basis, I mean, I couldn't see that happening. Do you?
What's that you're referring to? Sorry.
The lariat, yeah.
Oh, the lariat, yeah. So it remains an open question. There's actually some data that suggests, there's some combined data that suggests that the recurrence rate after atrial appendage occlusion and combined atrial appendage occlusion and ablation is lower than it would be without left atrial appendage occlusion. That's early data. So it's not worse, and it may be a little bit better. I don't know if you guys are familiar with those data, but the bottom line is we don't think it's going to be provocative. As far as the lariat goes, I don't know what the ultimate outcome of that will be. You know, it's 2 access points. There's more opportunity for mischief. I think there's issues there. So, but it needs to be tested. So, and who knows? Maybe it's more effective for stroke prevention. We don't know. So the bottom line is that we're open to the possibility of, in the patient who's oral anticoagulant intolerant, that's the population we're aiming for, because I think that's the one most at risk and most justifies some increased risk of procedural aspect. Interestingly, our neurologists, I agree with you. I think the risk is higher or potentially higher in the lariat procedure. Our neurologists love this procedure because they're fundamentally against implantable devices. They think there's some issue with that. So they're okay with the suture-mediated closure of the left atrial appendage. I'm open-minded enough. I've been wrong enough, long enough to be open-minded. So,
Thanks.
yeah.
Great talk.
Thanks.
Wonderful review of the literature. So with regard to, it sounds like we really need to learn a lot about the anatomy of the left atrial appendage, and I think you alluded to that in terms of planning these procedures. Which of our imaging techniques, is it 3D echo or is it CT imaging that really is critical for that?
Great question.
And do you have really a team of imagers and proceduralists that sit down? Then the other thing that always comes up is I think both interventionalists and electrophysiology interventionalists are interested in this, and any comments on
So I'll take the last comment first. In our institution, we've been very ecumenical about who does this. So while we the interventional cardiologists were involved with the PROTECT and PREVAIL trial, we've been very kind of open and thrown a broad net with the EP guys there. They've been interested but not actively involved yet. So, but there's been no effort to exclude. And I think their skill set actually matches very nicely here, and they have a great patient population. They do a lot of atrial fibrillation ablation. So we hope that they'll get involved. Actually, we're doing our first training tomorrow in Minneapolis, and half the group is going to be EP and half the group will be interventional. So we think it's best as a heart team. At Columbia, we have a heart team concept in reality. I mean, we have a valve center. I was talking to Kuzro about this last night. Becky Hahn, I don't know if you know Becky, but she's a world-class echocardiographer. She doesn't let me get away with anything. I mean, anything. She's terrific. And to go to your first question, the imaging really depends on what access you have to the expertise in your institution. So we are very lucky. We have echocardiographers who are world-class. We have, as I'm sure you do here, and we have folks who are very good at CT reading as well. And we've come to the conclusion that CT scanning, although it's very helpful in giving aspect kind of understanding about, sternal perspectives on the left atrial appendage and relationships and so on, they can be fraught with underfilling and some artifactual things which make it difficult for us to really say with any certainty there's no thrombus there, that the full atrial appendage has been visualized and so on, in spite of the fact we're doing very careful protocols for acquiring imaging and injection. So on balance, I think that a very good echocardiogram, TEE, can probably better characterize most of these appendages. You can, with 3D TEE, you can really characterize the shape and the size, and it's just been remarkable. And we've been burnt by the CT. We've done CTs that we thought were fully filled, And we go to the procedure, and sure enough, they're a chicken wing, and we can't do the procedure. So we've had enough of those failures that I'm becoming a convert to the echocardiogram side of the equation. Yeah. Yes?
Can you comment on what causes the pericarditis with the lariat? Is there necrosis of the appendage? Is it how much futzing around in there you do? And also, is the subxiphoid the safest approach for a dry tap, or can you go apical, or what else have you done?
That's a great question. The first one is, I think it's probably early enough that we don't get a lot of late pericarditis. We don't get patients coming back with pain. So I suspect that the necrosis, which probably occurs over days and weeks, not hours, is probably not the cause. It's probably the futz factor. We're in there a lot. If there's any blood at all released, I think that's probably irritating. So that's my sense of it. So we start everybody on colchicine ahead of time and so on. It's a bit of a bar mitzvah, but it works. As far as the atrial appendage, access to the pericardium, actually there's a guy at the NIH whose name's Bob Letterman who does a lot of great stuff. He's just this crazy scientist, mad scientist. I don't know that apical approach is necessarily helpful. In fact, the subxiphoid approach gives us a nice angle into the left atrial appendage, so the apical will put you too posterior. You need an anterior approach into the atrial appendage. So that seems to be okay, but there are other approaches to the pericardium. He's come up with one where he comes up the IVC, he pokes out the right atrial appendage, which is basically a continuation of the IVC, and puts you right into the pericardium, and you can seal that then out with a small plug afterwards. But it puts you into the kind of AV groove, and it's actually an interesting idea, and opens a lot of possibilities for other access points. Yeah. Other questions? So one quick, carotid stenting, I'm not going to say anything except about access and where we are with that. As you probably know, the FDA has approved carotid stenting for every category of potential patient that might be available or necessary or need it. This means that if they found either one or multiple devices safe and effective for this procedure. CMS, on the other hand, has decided not to pay for it, except in high-risk symptomatic patients, which comprise about 10% of the total population of carotid patients. This has left a whole host of patients, radiated necks and prior surgeries and all sorts of things, who cannot get the procedure, and not to mention medical comorbidities, who can't get the procedure. For about 10 years or 7 years, we had these post-market surveillance studies, which were prospectively gathered data sets. We have about 40,000 patients showing very good safety and efficacy of these devices, and in fact, CMS has refused to pay for this. CREST-2, which is a randomized trial, has an appendage registry, which allows patients to be treated in a registry format as a kind of attachment to CREST-2, and that's just kicking off. CREST-2 is a randomized trial between medical therapy and either surgery or stenting in the asymptomatic patient with severe carotid stenosis. And we were talking yesterday, it's a difficult trial to do because if you're a 65-year-old gentleman with a 95% lesion, do you really want to be randomized to medical therapy when we know that from ACAS and ACST that there's actually a beneficial effect of surgery? And there's not the same level of data I would submit on medical therapy. I'm a big fan of medical therapy, but I'm not sure that data exists. So it's going to be problematic, and my concern, I think we all share the same concern, is that we're going to get the patient with the 60-80% lesion who is not as great as risk, and we're not going to be able to demonstrate the benefit of intervention in a low-risk population. So we'll see. We'll see what happens. Right now, CMS will pay for the CREST-2 registry patients who are enrolled. So we'll see how that plays out. That's going to be, if that's the way it is, it's going to be like that for the next 6 to 8 years probably, unless something changes. Okay, thanks, Khusro.
The preceding program is copyrighted by Emory University.